Welcome to our video on renal tubular functions. After watching this video on renal tubular functions, you should be able to discuss the functions of different nephron segments, including proximal tubules, thin and thick ascending limbs of Henle loop, distal convoluted tubules, and collecting tubules. You should also be able to explain the clinical manifestations of Fanconi syndrome, hyper versus hypoaldosteronism. Let's take a look at a single nephron unit. We start with the glomerular capillary filtering plasma into the Bowman capsule. The filtrate travels down the proximal tubule, thin descending limb of Henle loop, thick ascending limb of Henle loop, distal convoluted tubule, then collecting tubule. Now we will take a closer look at the functions of each of these tubular segments. Starting with the proximal tubular segment, we take a look at what a cell lining the proximal tubule does. Here we have adjacent proximal cells held together by tight junctions. The apical or luminal side is on the left and basolateral side is on the right. Normal kidneys typically filter approximately 180 liters of plasma daily. The kidneys must therefore have a large capacity to reabsorb most of this filtrate along with its electrolytes and small solutes. For this reason, proximal cells have microvilli, also known as brush border, on the apical surface to increase the surface area needed for the big reabsorption job. Proximal tubules reabsorb the bulk of all electrolytes and almost completely all of the filtered glucose, amino acids, and low molecular weight proteins that cross the glomerular filtration barrier. Now we will show you some of the basic transporters in proximal tubules. The sodium hydrogen exchanger, also known as NHE3, the sodium phosphate cotransporter or NPT, the sodium glucose cotransporter, also known as SGLT2, the sodium amino acid cotransporter, and a water channel called aquaporin. The tight junctions between proximal cells turn out to be quite leaky, which means that there can be passive paracellular reabsorption of small solutes along with water. Last but not least, we have the ubiquitous sodium-potassium ATPase, where 3 intracellular sodium are exchanged for 2 extracellular potassium. Proximal tubules basically reabsorb almost everything from the filtrate. Because proximal tubules reabsorb almost everything, patients with proximal tubular injury from ischemia or exposure to toxins can lose excessive sodium, glucose, amino acids, low molecular weight proteins, etc. into their urine. When patients develop isolated and extensive proximal tubular injury and present with severe wasting of all of these solutes, it is referred to as Fanconi syndrome. Key points to remember about proximal tubules. Proximal tubules have microvilli, also known as brush border, on apical surface to increase the surface area needed for the big reabsorption job. Proximal tubules reabsorb the bulk of all electrolytes and almost completely all of filtered glucose, amino acids, and low molecular weight proteins. Proximal tubules can reabsorb all filtered glucose if the filtrate glucose concentration is less than 180 to 200 mg per deciliter. The junctions between proximal cells are leaky and allow for passive paracellular reabsorption of small solutes along with water. Fanconi syndrome refers to isolated proximal tubular dysfunction manifested by excessive wasting of sodium, glucose, amino acids, and low molecular weight proteins. Key clinical knowledge pertaining to proximal tubules. SGLT2 inhibitors are used clinically to induce glucosuria, thereby improving blood glucose level in patients with diabetes mellitus. Because of the high metabolic activity and demand in proximal tubules, they are highly susceptible to ischemic injury. Acute ischemic injury resulting in proximal tubular cell death is called acute tubular necrosis, commonly known as ATN. Proximal tubular cells also play a major role in the reabsorption of filtered bicarbonate, a base, without which our blood would be very acidic. Let's see how this is done. Here we have our simplified proximal tubular cells with all transporters removed. We are just going to focus on how bicarbonate is reabsorbed with sodium. The first step in bicarbonate reabsorption is the secretion of hydrogen into the lumen. This occurs predominantly via the sodium-hydrogen exchanger NHE3. The secreted hydrogen combines with a filtered bicarbonate to form carbonic acid. With the help of the enzyme carbonic anhydrase, carbonic acid is split into CO2 and water. CO2 freely diffuses into the cell, while water crosses the cell via water channels called aquaporin. Inside the cell, the enzyme carbonic anhydrase recombines CO2 and water to reconstitute carbonic acid. Carbonic acid then redissociates into the proton hydrogen and bicarbonate. Hydrogen gets redelivered into the lumen to pick up another filtered bicarbonate to reabsorb, while the regenerated bicarbonate gets reabsorbed into circulation via the basolateral sodium bicarbonate cotransporter. This multi-step process is how bicarbonate is reabsorbed by proximal tubules. Key points to remember about proximal tubular bicarbonate reabsorption. Proximal tubules reabsorb 80 to 85% of all filtered bicarbonate. Bicarbonate reabsorption is a multi-step process. The key enzyme involved is carbonic anhydrase. Inhibition or mutation of carbonic anhydrase can lead to severe bicarbonate wasting and acidemia. Going down the loop of Henle, we first take a look at what a cell lining the descending limb does. All we need to know about the thin descending limb is that it is very permeable to water. At this segment, water is reabsorbed into the medullary interstitium, leaving the filtrate in the lumen more concentrated. Recall this is the first step required in the countercurrent multiplier. Water reabsorbed from this segment gets picked up by the hyperosmolar vasa recta and returned to the venous system. Key points to remember about the thin descending limb of Henle loop. At the thin descending limb of Henle loop, water is passively reabsorbed into the medullary interstitium. The water that is reabsorbed is then returned into circulation via the vasa recta. The thin descending limb of Henle loop is a vital component of the countercurrent multiplier system. Moving on to the thick ascending limb of the loop of Henle. Let's see what these cells do. Here is a cell from the thick ascending limb of the loop of Henle, apical on the left, basolateral on the right. On the apical side, we have the sodium-potassium 2-chloride cotransporter, or NKCC, which serves to reabsorb sodium, potassium, and chloride from the lumen. Once inside the cell, sodium and chloride get reabsorbed back into circulation, while potassium recycles back out into the lumen via the renal outer medullary potassium channel ROMK. Recycling of the positively charged potassium into the lumen makes the lumen positively charged. This positively charged lumen repels the positively charged calcium and magnesium from the lumen across the paracellular pathway where they are reabsorbed back into circulation. Optimal calcium and magnesium reabsorption is dependent on the positive luminal charge driven by potassium recycling. Now focus our attention to the basolateral side. There is a calcium sensing receptor. At high serum calcium levels, calcium will bind to its receptor. Binding of calcium to the calcium sensing receptor leads to the inhibition of the potassium channel ROMK. This inhibits potassium recycling, thus the loss of the positively charged lumen needed for optimal paracellular calcium reabsorption. Calciuria will thus occur to correct the high serum calcium level. Magnesiuria may also occur. Key points to remember about the thick ascending limb of the loop of Henle. The thick ascending limb reabsorbs sodium, potassium, and chloride via NKCC. Recycling of potassium back into the lumen creates a positively charged lumen that facilitates the paracellular reabsorption of calcium and magnesium. Binding of calcium to the calcium sensing receptor inhibits ROMK, thus potassium recycling. The loss of the positively charged lumen generated by potassium recycling reduces calcium and magnesium reabsorption. Moving on to the distal convoluted tubule. What do cells at this segment do? Here we have a cell from the distal convoluted tubule, abbreviated as DCT, luminal side on the left and basolateral side on the right. The ubiquitous 3-sodium 2-potassium ATPase transporter on the basolateral side. Now shifting our attention to the apical side. The DCT has an apical sodium chloride cotransporter, or NCC. NCC reabsorbs the filtered sodium and chloride back into circulation. The DCT is also involved in calcium reabsorption. Here, calcium is reabsorbed at the apical surface via a calcium channel, then back into circulation via the sodium-calcium exchanger. Key points to remember about the distal convoluted tubule. The DCT reabsorbs sodium chloride via the sodium chloride cotransporter. Calcium reabsorption occurs via the apical calcium channel and basolateral sodium-calcium exchanger. Our last nephron segment of interest, the collecting tubule. So what are the functions of these cells? We are at the last nephron segment, the collecting tubule. There are 3 distinct cell types at the collecting tubule: principal cell, alpha intercalated cell, and beta intercalated cell. Apical on the left, basolateral on the right. In the principal cell, sodium is reabsorbed through the epithelial sodium channel, referred to as ENaC. Once sodium gets into the cell, it gets transported back into the blood via the sodium-potassium ATPase transporter. Note that the entry of sodium into principal cells creates a negatively charged lumen. The basolateral reabsorption of sodium via sodium ATPase leads to intracellular potassium accumulation. Both the negatively charged lumen and high intracellular potassium concentration creates a favorable electrical and chemical gradient for potassium secretion into the lumen. This is how potassium is predominantly secreted by the kidneys. Next door, we have the alpha intercalated cell. This cell is equipped with a proton transporter called hydrogen ATPase. The negatively charged lumen also facilitates hydrogen secretion via hydrogen ATPase. This is predominantly how the kidneys get rid of acid. Alpha intercalated cells also have a hydrogen-potassium transporter, where potassium gets reabsorbed in exchange for the secretion of a hydrogen. Hydrogen secretion via the hydrogen-potassium transporter is only minor. Of note, the hydrogen that gets secreted from alpha intercalated cells come from carbonic acid made out of CO2 and water with the help of the enzyme carbonic anhydrase, similar to what happens in proximal tubules. While hydrogen gets secreted, bicarbonate is reabsorbed via the basolateral bicarbonate chloride exchanger. Next door, we have the beta intercalated cell. This cell essentially functions as a mirror image of the alpha intercalated cell. Instead of secreting hydrogen and reabsorbing bicarbonate, beta intercalated cells do the reverse. They secrete bicarbonate into the tubular lumen in exchange for the reabsorption of a chloride. Hydrogen is reabsorbed on the basolateral side. Aldosterone is a hormone that can bind to mineralocorticoid hormone receptors in principal and alpha intercalated cells to upregulate the expression of ENaC, potassium channel, sodium-potassium ATPase, hydrogen ATPase, and bicarbonate chloride exchanger. Overexpression and activity of these transporters can result in an increase in sodium reabsorption and an increase in the secretion of potassium and hydrogen. Clinically, patients with hyperaldosteronism can present with increased sodium reabsorption, thus hypertension, hypokalemia, and metabolic alkalosis. On the other hand, hypoaldosteronism can lead to the opposite, which is reduced sodium reabsorption, thus hypotension, hyperkalemia, and metabolic acidosis. Finally, water reabsorption also occurs at the collecting tubule via a water channel called aquaporin 2. Water reabsorption here is regulated by a hormone called antidiuretic hormone, commonly referred to as ADH. This hormone is also called vasopressin. What this means is high ADH levels promote avid water reabsorption back into circulation, while low levels of ADH or absence of ADH reduces water reabsorption, thus increased water excretion into the urine. Key points to remember about collecting tubules. Collecting tubules reabsorb sodium via ENaC and leads to the subsequent secretion of potassium and hydrogen via ROMK and hydrogen ATPase respectively. Aldosterone upregulates the reabsorption of sodium and secretion of potassium and hydrogen. Hyperaldosteronism can cause hypertension, hypokalemia, and metabolic alkalosis. Hypoaldosteronism can cause hypotension, hyperkalemia, and metabolic acidosis. Water reabsorption occurs via aquaporin 2. Aquaporin 2 is upregulated by the antidiuretic hormone, ADH, also known as vasopressin. High ADH level increases water reabsorption, while low ADH level increases water loss into the urine. Let's summarize basic tubular functions. We start with the glomerular capillary, filtering plasma into the Bowman capsule. The filtrate then drains into the proximal tubule. The proximal tubule reabsorbs 60 to 80% of filtered sodium potassium chloride phosphate, all of glucose, and most of amino acids and low molecular weight proteins. The proximal tubule also reabsorbs 80 to 85% of all filtered bicarbonate. The urinary filtrate then drains into the thin descending limb of Henle loop, where water is passively reabsorbed into the medullary interstitium. Next, the filtrate drains into the thick ascending limb of Henle loop, where 20 to 30% of sodium, potassium, and chloride are reabsorbed via the sodium-potassium 2-chloride cotransporter, NKCC. At this segment, calcium and magnesium are also reabsorbed paracellularly in between adjacent thick ascending limb cells. Next, the filtrate drains into the distal convoluted tubule, where 5 to 10% of sodium chloride is reabsorbed via the sodium chloride cotransporter, NCC. At this segment, calcium is also reabsorbed transcellularly via the calcium channel on the luminal side and sodium-calcium exchanger on the basolateral side. Finally, the remaining filtrate drains into the collecting tubule, where only less than 5% of all filtered sodium is reabsorbed via the epithelial sodium channel ENaC, with subsequent potassium and hydrogen secretion via ROMK and hydrogen ATPase respectively. This process is upregulated by the mineralocorticoid hormone aldosterone. At the collecting tubule, water is also reabsorbed via the water channel aquaporin 2. This process can be upregulated by the antidiuretic hormone ADH, also known as vasopressin. In summary, we just reviewed the functions of all nephron segments. We also discussed the clinical manifestations of Fanconi syndrome. Fanconi syndrome refers to any condition that leads to generalized proximal tubular injury, resulting in urinary loss of multiple electrolytes, including sodium, potassium, and bicarbonate, glucose, amino acids, and low molecular weight proteins. Hyperaldosteronism is associated with increased sodium reabsorption via ENaC and increased potassium and hydrogen secretion via ROMK and hydrogen ATPase respectively at the collecting tubule, resulting in hypertension, hypokalemia, and metabolic alkalosis. Hypoaldosteronism is associated with decreased sodium reabsorption via ENaC and decreased potassium and hydrogen secretion via ROMK and hydrogen ATPase respectively at the collecting tubule. Hypoaldosteronism is associated with hypotension, hyperkalemia, and metabolic acidosis. That's it for renal tubular functions.